Okay, thank you. Welcome back, everyone, to our first panel discussion. This panel is going to be on addressing age-specific needs and preferences throughout adulthood. I think that our sessions earlier today provided a great setup for the discussion we're about to have with 4 distinguished panelists. And this is where we really need to dig into, as we've already heard, there is a life cycle going on here. And it's not just about when I get my acute care for cancer, it's the before, during, and after, and we hope very many decades after, and taking account for patient preferences, as well as you will hear, diversity among the patient population. And so what I'm going to do is ask each one of our panelists to introduce herself or himself. We see your name and affiliation. We're going to start with Darcie Green. Although her video may have stopped. Let's start with Danielle. And Danielle, tell us how it is that you from your organization are involved in a panel on this topic. What's your connection to the topic, Danielle?
Good afternoon. It's an honor and a pleasure to be included today. I am an attorney by training, but a caregiver and patient advocate by calling, by vocation, if you will. Most importantly to me, I am a full-time caregiver for both of my parents. My mother was diagnosed with stage 4 lung cancer 5 years ago, almost 6 years ago. And my father, though not a cancer survivor, has several chronic conditions and diagnoses that I help him manage. And I'm here today probably for the same reason as most of us, that along the way of learning how to be a full-time caregiver, I noticed problems that didn't seem to have solutions. And I thought there must be a better way. So in the course of finding these problems and seeking solutions, I thought, well, there must be a way to network and find a solution that way. And so early on in my mother's cancer experience, I know that that word was used earlier, I discovered a booming and very healthy social media space in cancer advocacy that is getting larger and more robust and more supportive by the day. And so now what I primarily do is network between constituents in the social media space. I wear many hats for many different nonprofits. I am a legal fellow for Triage Cancer, which is a nonprofit founded by cancer attorneys. I am an advocate for the Longevity Foundation in several of their projects, and I also help with social media projects for several smaller nonprofits.
Great, thank you very much, Danielle. So your personal experience led you into this broad, still evolving network of contacts in the field. So very helpful, and it's interesting how you got started there. I think Darcie's back. So Darcie Green, could you introduce yourself and remind us how it is you find yourself on this panel?
Yes, hi, thank you for having me here today. My name is Darcie Green. I'm the Executive Director of Latinas Contra Cancer. I'm also a patient advocate. And I find myself coming to this work. I've always had a passion for the issue of cancer. I lost my grandmother to cancer, and I worked in the healthcare field and became the executive director of this organization a few years back. And I'm very passionate about health disparities. And what I plan to bring to the conversation today is a focus on the specific needs of low-income cancer patients, of Latino cancer patients, of undocumented cancer patients, and the unique obstacles that they face when navigating their cancer journey, and how these social determinants of their health really have to have a personalized plan and need to be factored in when thinking about the best health outcomes for them.
Greg, it's good to have you on this panel, Darcie, and I hope you were listening when we had the Senator Van Hollen and the Congressman Carter on before, because they were saying that they have their ears to the ground on these issues with regard to disparities and so forth. So maybe you've got an avenue into the Congress and the House of Representatives and the Senate on those issues. Thank you.
Thank you.
Glad to have you on. Dr. Muss, Hyman Muss, tell us what you're doing in this panel, sir. And I believe you're on mute, sir.
I hope it's not age alone, which is why I was selected, but I am a medical oncologist, and I've been interested probably for the last 10, 20 years of my career in cancer in older adults and trying to improve their care. They are also really a very vulnerable and huge majority of our cancer patients that we really have never adequately gotten into clinical trials and treated. So myself, and I think I speak for Dr. Dotan as well, are devoting a lot of our career to making this better. And I got in it through a great mentor, and it really changed my life and my research and my practice.
Well, thank you. That change in your life is benefiting all. I know that very well. Thank you. Let's go to Dr. Efrat Dotan from Fox Chase.
Hi, everyone. Thank you so much for including me in this panel. So like Dr. Muss, I am an oncologist, a medical oncologist. I focus on treating GI cancers, but specifically GI cancers in older patients. And I'm also extensively involved in clinical trials that are focused on the elderly population, thinking about how do we refine therapy and approach this very vulnerable patient population in a more appropriate way to fit their goals, objectives, and what is really important to them, not just looking at endpoints that are cancer endpoints, but maybe more patient-specific endpoints. So I'm really thrilled to be part of this panel.
Great, thank you very much. And by the way, this session will go to 2:35 p.m. Eastern, 2:35 Eastern. Maybe about 10, 12 minutes before that, we'll go to audience Q&A, but please feel free to submit your questions before then if you like. We're gonna do something a little different. We're gonna do a quick lightning round where I'm gonna ask one question of our panelists, and it's basically an issues question. And that the question's going to be considering the patient population whom you represent or with whom you work the most, what's the one issue that if solved, the one issue that would solve would make a leap in improving cancer care for adults? You know, as I posed this earlier on in the day to the senator and congressman, if you could push one button or pull one lever, what might that be? And let's go in reverse order now. Let's start with Dr. Dotan on that. Efrat, if you could push one button and make something happen, what would it be? Just briefly.
Well, I think I touched a little bit about a big part of my career focusing on elderly specific clinical trials and understanding how what we do affect this vulnerable population. I think when we treat older patients, we function in basically in the dark. We don't really know. We don't have a lot of evidence of what our treatments are going to cause, how they're going to affect the patient's outcomes in terms of function, not just in terms of their cancer, how their side effects and the tolerance are going to be with the various treatments. So if I could improve how we are moving the field forward, and if I could inject those thoughts into all these amazing clinical trialists and researchers that are doing cancer research, not just to think about what it's going to affect the cancer, but what their research and their treatments are going to do to the patient and to older patients that are the majority of the patients that are going to receive these treatments. I think that's going to really move the needle forward.
Thank you. And we would hope that we would have been there already, Efrat, but I guess we're not quite there yet. And you know very well, given the span of knowledge that you've got about the field. So Hyman, if you could just push that one button, sure. What would that be?
Well, I think the greatest need for older cancer patients is to develop a appropriate way in busy clinical settings of doing geriatric assessments on the patient, which would to give us optimal ways to care for them. And this would include, as our terrific first speaker, their goals, because goals of older patients are frequently a lot different than younger patients and children and young adults that we've talked about at the conference. And also providing them with adequate caregiver and social support, which for many of our older population is really lacking. But the geriatric assessment can define issues related to function, cognitive status, nutrition, things that are crucial and which can be addressed, and which we frequently, when we focus just on the cancer and its treatment, we miss. And so we miss a great opportunity to help older people.
Hyman, do you consider that there are good tools for geriatric assessment? When you mention that phrase, do you think of a tool right away?
Yes, so yes, there are, and I would say there are many good tools. I favor the Cancer and Aging Research Group tool, CARG tool, and you can look that up on the web. There's great patient information, and a lot of it is self-administered and scored, and it's terrific, and it's available. The problem for physicians, nurses, APPs is time. The most precious gift is time, and having the time to implement it, get the data, and then when you identify problems, being able to make the appropriate referrals. But there are great tools available.
Thank you very much. So geriatric assessment, and yes, there are great tools available, but time is an issue. Thank you. Over to Danielle. Danielle, as a caregiver and a patient advocate, if you could press that one button, what would it be?
Hopefully my button would cover not just one issue, but an umbrella or category of issues. Best described as not assuming what a particular family's needs are or what you might imagine them to be, but to find out what they are in actuality. I wholeheartedly believe, and I know I'm not alone in this, that if caregivers were better supported, outcomes overall would be better for cancer survivors. Unfortunately, even though caregivers and families are not cut from whole cloth and all the same, a lot of the advice that we get as caregivers and family members and support team members seems to be cut from whole cloth. It seems rather shallow and vacuous. If I had a nickel for every time I've been told to eat more vegetables and get more sleep, I could retire on those nickels. But that doesn't get the paperwork done or the meds counted out or the households cleaned. And most caregivers are trying to clean 2 households. So including caregivers on your focus groups, including caregivers on your patient advocacy teams at your institutions, and including caregivers when you make decisions that affect cancer survivors overall would hopefully improve the support systems that undergird so much of the treatment plans, because without caregiver buy-in, frankly, treatment plans will fail, especially at home.
So caregiver engagement early, throughout, and often, correct?
Correct. Thank you.
Got it. Point well taken.
Thank you.
Darcie, over to you. Gosh, there are probably a bunch of buttons you'd like to push and a few levers you'd like to pull. What's the one toward the top, Darcie?
And I have to give you 2. I know it's a lightning round, but I'm hoping you'll give me 2 bolts.
For you too. Okay.
The first one is universal health care. Our clients struggle to even access cancer treatment at the very basic starting point. But universal access to healthcare that is a single payer at least at the point of consumption by the consumer, because it's a tangled web of payers, and that can bring a lot of stress for clients who are particularly the elderly or adults who struggle economically. So that's one bolt: universal access to healthcare. Unburden our community from that. And the second would be universal access to financial assistance for those cancer patients who suddenly lose income or jobs. We have clients who choose not to get cancer care, adults who are caring for families, the elderly who don't want to be a burden. They choose not to get cancer care because of the income it may have on their job, the impact it may have on their job, the impact it may have on a caregiver's job. It's madness to me that we allow cancer patients to go unhoused, to go hungry, to lose income without any kind of safety net. And particularly if you're a business owner, if you're undocumented, if you're someone that works in a place that doesn't offer sick leave or quality vacation, adequate sick leave, or you're not able to access state funds, you are left with just $0. And that makes it very difficult for you to get the best health outcome from your cancer treatment or to stay relaxed. So those are the 2 things I would do: universal health care and some universal access to financial assistance for those who've been diagnosed and need to take time away from work.
Those 2 are deservedly high priorities, and it has to irk all of us to consider that any of our, fellow Americans have to make a choice between getting on the bus and going to work or getting cancer care, or putting food on the table and getting cancer care. To have to refuse cancer care that we know so often is helpful it's shameful, I guess, if you don't mind my reading between your lines there, Darcie. So I want to return to an issue that Danielle brought up very well, and I hope to get all 4 of you weigh in this, Danielle, but you started it maybe unintentionally, and that has to do with incorrect assumptions about a patient's preference. So patient preference, and you alluded to that earlier, and actually Jan White in her keynote alluded to it. Tell us a little bit why this goes wrong sometimes and how we might reverse that problem. So why does the issue arise, and then what can we do about it? Start with Danielle.
Thank you. So something that Jan said really beautifully before, when she was told by members of her team, you shouldn't be able to be doing some of the things that you're doing. It reminded me of my mom and her experience. The way that she introduces herself to people who don't know her well is to say that she's always the first person on the dance floor at a wedding. She's in her mid-70s, and she's still always the first person on the dance floor at the wedding. And when she recently went through a long hospitalization, the PT team, though extremely well-intentioned and obviously very professional and kind, did not understand that someone in her mid-70s would want to be the first person on the dance floor at a wedding. And unfortunately, that led to misunderstandings about goals from the very start. And seeing this firsthand, being in the trenches with my mother, I realized that there are, even among the most well-intentioned providers, there are assumptions that are made. You know, she's my mom. I've known her obviously my entire life, and she's always seemed to me to be about 17, 18 years old. But that wasn't the case for them. And there were awkward conversations where I sort of point blank said to the PT team, I wonder if you would tell a 19-year-old she'll never walk again. Would you tell a 19-year-old you'll never walk again? And that made them think, and that made them double back on their assumptions. Unfortunately, I'm privileged and somewhat well-resourced, and I felt enfranchised and empowered to have those conversations. And as we all know, that is not always the case. So I don't know if there is some on-the-ground empathy training, some sort of walking in someone else's shoes training, but that's usually what I bring up in these conversations. Unfortunately for my family, it has meant that when she meets a new provider, my mom introduces herself as, I'm 17, treat me accordingly.
Point well taken. That's a great illustration. And you also lay out the frustration very clearly. I wonder, Efrat, from your standpoint as a provider, have you been party to misinterpretations and or ways to get around these incorrect assumptions?
Yeah, absolutely. And I'm actually going to take it to the other direction. I think when we're treating cancer patients, and I often see patients with advanced disease where we're talking about aggressive chemotherapies, and they've already met with a surgeon and a radiation oncologist and multiple other people. And it is shocking to me that I would walk in the room and I would ask them, what do you want? What are you hoping to get out of this treatment now that you met all these people? And more than once, I would get the answer, oh, you're the first person who actually asked me that. And I think as providers, we are so tied up with thinking about the cancer and focusing on how can we treat this? How can we get rid of it? How can we fix this problem? And it may not be the primary objective of the person who's sitting in front of you. And it might be that an older adult, their primary goal would be to feel well and have quality of life rather than go through an aggressive surgery that is very likely to cause them significant morbidity and make them disabled. And, you know, this was mentioned by Hai as well. You know, this concept of doing a geriatric assessment is really delving into what is important to this patient, what is happening to this patient outside of this cancer, and how can we provide comprehensive care addressing all of these issues without assuming that either everything is fine and the patient wants what we think they want.
So it sounds like, from what you're saying, Efrat, that we ought to design this into the patient encounter to make sure we probe on these issues rather than walking in with a raft of assumptions. And since you mentioned Hai Muss on this, Hai, what do you think? How do we get around these incorrect assumptions? How do you do it? And I think you're still on mute. Hi, I think you're still on mute. There you go.
When I meet a patient for the first visit, I usually introduce myself, but I say, tell me about yourself. Tell me about yourself. I love that line. I teach my residents to do it because if you're if you've unfortunately had a lot of second opinions and first opinions, you know, they ask people, do you smoke, drink, do illicit drugs? That's called the social history, which is about worthless. I want to meet that 80-year-old on illicit drugs. I think I'd learn a lot from her, being a little facetious. But I ask, tell me about yourself. And that helps you learn a lot about the person. Do they define themselves by what they do, what their goals are, et cetera? And you can learn a lot. And then I think you probably know when you see that patient whether your treatment has a potential curative intent or not. And that's a key thing. And for potentially curative therapy, the issues may be different from the patient than for palliative therapy. If you can't cure a cancer, it's really all in the palliative care realm. So knowing that, and then finding out what the patient's goals are, and not your goals, but the patient goals, and trying to put them together is key. And it's also very important to, when you have an older patient, especially, frequently you have family members in there. And sometimes the family members' goals aren't the patient's goals either. The family may want many more things done for the patient than the patient wants for themselves. And I think it gets to Efrat's comments on quality of life. So I think defining goals, and I'll end it by saying I had a unique experience a few months ago. Was a woman in her 70s, and she said, "Doctor, before you ask me any questions, I would like to read you my personal statement." And she actually had a 3-minute personal statement. And I got a copy of that, and I think I'm going to incorporate that into some of the visits because it was just terrific. It was like, treat me like I'm a 17-year-old, or I want to be on the dance floor first. It was perfect. And I learned more from that than the rest of the visit.
Well, the tell me about yourself is just a wonderful entree, but I just want to go back, Hi. Is there a particular hint or a tell that relates to you whether you will be going down the palliative route or the curative route? What do you hear that tips you off?
Well, usually you know from the patient's history and their medical information, not always.
Okay.
But I suspect for most of the patients that Efrat and I see, we know whether our treatment is going to be for curative intent or palliative intent. Different than Jan White's talk today with lymphoma. You don't know where you're going to be quite in there, but the goal there was probably curative intent. So you kind of know that. But I will tell you, frequently patients, in spite of numerous visits, don't know what the intent of the treatment is as far as the cancer. And so I think it's very important. And oncology is so complicated today that frequently the referring docs who send you the patients don't always know what the goal of the care is. So I've learned from my referring docs, at the top of your notes, put goal of therapy, whether it's curative or not. And just to clarify it, because I was somewhat surprised, but we get into all our jargon and drugs, and frequently our own referring people are uncertain of what we're doing.
So you end up, you're going to put something at the top. That is the goal, so no one misses it later on. It sounds as though you have maybe a prior set of assumptions based on the clinical history, what you see, but that could be steered one way or another depending on what the patient relates to.
So what I'm learning from here, I may need to change my style, as old as I am, and have patient goals under there too, which can be much more nuanced and complicated.
Thank you, Dr. Muss. Excellent.
That is a great point.
Thank you.
Well, you're a great moderator, Cliff. That's why you're doing this.
Well, we're all learning. We come together not just to talk, but to listen. So, Darcie, you and I know that you have a few things to say about being the subject of incorrect assumptions. Would you kind of share your views on how that occurs?
Yes, we see this happen because of age. We also see this happen when there's language barrier. We also see this happen culturally. There's many ways that a cancer treatment plan or expectations get lost in translation, because it's not just even like English language versus a different language. Healthcare itself has its own language. And as we heard Dr. Muss say, it's very complicated. And it could be overwhelming and intimidating for a patient who's gone in who maybe this is their first time having this level of interaction with a healthcare system. This is their first time having a chronic condition that is going to need them to be interacting with different specialists and the healthcare system in that way. So it can be very intimidating. So what I will say, because it's already been covered on the treatment end and the hospital end of the things that can be done to help alleviate those obstacles, from the other side, as a nonprofit that works in patient advocacy, we try to empower and educate our clients and our patients to know what to ask, what they can ask, what they should be asking, what they should be saying, what they should expect from their medical provider. There's so much work that can be done to educate the patient population about their insurance, about their hospital system that they visit, about what to expect and what they should be asking for. Because so many times our clients just don't even realize they had an option to and I'll say politely push back, right? Or to ask different questions, or to introduce an idea that they Googled, right? And they saw. I know that sometimes can be discouraged, but we do want people to do research as well. So as an organization, we work to educate and build patient populations that feel more confident in their knowledge of the healthcare system, in their knowledge of cancer, and also to remind our patient population that it's a partnership, it's a collaboration. Your treatment plan, and this goes for any condition, right? It's a collaboration because it's still your body, and you are expert in what's going on in your body. So you are walking in with that level playing field of this collaborative effort to get you well.
So it's interesting, and it kind of echoes what Hy just said. If you can walk in, if you know that walking in with your own personal statement will give you a much better kind of a personal, what have you, negotiation or decision-making role, that's important. But how do we make sure that patients who are struck with having cancer and all the sort of how that can just be so anxiety provoking and unsettling, how can we help them get the focus to actually appear when they see the provider that well equipped? Is it practical to expect that, Darcie, or do organizations like you try to get out ahead of that curve?
I think that's where the service providing, the CBO nonprofit sector plays a really big role. It's healthcare there's a lot of things that make the world go round, and that collaboration is important. So whether it's having a patient advocate, we know right now that patient advocates, they're available. Many private patient advocates can be expensive to hire. That's one of the reasons I went into patient advocacy, so I can just do this work for free for people. It would be great if everybody had a champion next to them. We know hospital sites have ombudsmen and other folks, but they're not, they still work within that system. It's always great to have an independent person who understands your background, understands what you want, and can help you effectively advocate for the outcome and what you want to have happen out of that meeting. So I would say a bigger investment in these nonprofits like ours, and there's plenty across the country that are working to help empower and to help bring that confidence to patients, and even attend these meetings with them so that nothing is lost in translation, and so you can get the best outcome.
Good. In a moment, but right now, not right now, I'm going to come back to you, Darcie, if you don't mind, about improper cultural assumptions. You raised that issue, and I'm curious to hear what you might say about that. But Danielle, would you reflect on what you just heard? How can we empower patients so that when they walk in, they know to have the personal statement, as Hy talked about, or others? How do we get them ready for those visits? Do you have any thoughts or advice on that, Danielle?
I do. I think the points made about the nonprofits is so spot on. Where would we be without the nonprofit organizations that we have in the patient advocacy space? From suggesting questions to ask of your providers to giving tips about who you can connect with if you don't feel answered when your questions have been asked. In addition to that, I would say that the points so beautifully just made by Darcie are also indicative of why we need to invest in and celebrate caregivers. People who have someone who knows them very well and loves them very much, who they would like to bring to these appointments to be that second set of ears who can take in medical information and also help the patient remember who they are and what their goals are, is crucial. It's crucial to a better outcome, as I said before, but what that actually means is you need to enable caregivers to be able to sit in those chairs. You need to encourage them to be a part of the conversation, not discourage them. You need to enfranchise them to ask questions, not disenfranchise them or make them feel silly for asking 1,000 questions. Speaking from personal experience, over long courses of treatment, my parents' providers have recognized that I'm sort of the VP of communications in our family. That is one way a caregiver can serve a patient or a family. It's not the only way, but it is a way. And so attempting to be as receptive as possible to a family member who may serve that role, while acknowledging that the patient is primary in the room, still accepting when that patient may want a caregiver to speak for them, is sometimes uncomfortable for providers, which, speaking as an advocate and certainly as an attorney, I can understand. But that's part of building that relationship. Like Dr. Muss had said, if part of the personal statement is, my daughter is my VP of communications, please proceed with her because I've just tuned out because this is big and scary for me, I'm sure that Dr. Muss would take that seriously. Yeah. And I think we need to see more of that across the system.
Thank you very much. In a moment, I'm going to ask you to answer a question we just got in, which was basically, hey, what was in that personal statement? What were the items in there? So I'm going to come back to you in a moment on that. Efrat, can you shed any more light on how clinicians can make that adjustment, whether it's with an assessment tool or asking the question Hy posed? Tell me about yourself. What other adjustments can clinicians or providers more broadly make insofar as interacting with patients and or their caregivers, as we just heard from Danielle?
So I think we all have to recognize that we have somewhat of a limitation when we come into this to seeing these patients, and what jumps up at us is the cancer and immediately what we should do about it, and we tend to forget. And I think just acknowledging that we don't think about this enough is the first step. So I always tell this story. I had a young surgeon, he just started, and he met a man in his 80s who had early stage colon cancer, and he was scheduled for surgery. And the patient was scheduled for surgery 3 times, and each time showed up, and just before, was going into the OR, decided that he doesn't want to have the surgery. And after this happened 3 times, the surgeon came to me and said, I have no idea what's going on with this person. He is just weird. There's something off. Can you please see him? And it ended up, what this patient needed is exactly that. Somebody to put away the medicine and walk in the room, acknowledging that there is a whole life to this man, a whole set of fears, a whole set of needs that was just not addressed. And we did a geriatric assessment on him. We evaluated him more comprehensively, and we're able to get him through to this surgery fitting what he really needed, that support system. And so I really do think it starts with just us understanding that we are missing that piece. It all starts with just communicating with the patient. That surgeon has become my go-to person for treating older patients. He's really become an amazing counterpart and really took on this element because of this case. So I'm hoping more education, more training of our young physicians, as they're going to see a huge amount of older patients in their practices, is just going to continue to transform the way this is being done in practice.
Well, great. You better hold on to the text information for that surgeon. Sounds like a great partner. So Hy, back to you. We did, like I said, we had that question about what would go into that personal statement. Do you remember any of the criteria or items?
Yes. So it opened up with telling me about her, that she considered herself in great health, which we would all probably agree on. Some people tell you in their great health and they're not, but she was in great health. She actually crewed with, I think, the UNC crew team. I didn't even know we had one till then. And she ran several miles a week. She was very interested in music and read a lot, and told me about walking several miles a few days a week, all things very important to her, and that she hoped that her treatment would do as good a job as possible to maintain as many of these things as possible. And I found it really charming, and it was interesting. It was a video visit, and her daughter, who was a healthcare professional, and a son who was IT guy, when she did it, I could see them recoiling a little bit. Oh, mom, you know, and I learned so much from that, and it was terrific. And now I'm starting to work on a little project to see if we can look at that in the clinic, because it does take a little time, but I think it's going to be well worth it and allow you to be a better doctor or nurse. And I just want to get back to something that Danielle and Darcie have said, that part of the geriatric assessment is social support. And we ask a lot of questions because your mother is very fortunate to have you, Danielle, there, but we have a lot of people with no support. And it's a team game to care for older people. And frequently one of the most important people on the team is the social worker.
Thank you.
You know, who can find help for that patient. If they live alone and don't have a lot of support, can get them to one of the wonderful aging centers we have. Frequently find a lot of other opportunities for a lot of those patients who don't have support, Meals on Wheels, etc. So it's really a team. And like Efrat said, none of us can do it all. And it's not a one-time thing. So the GA, to me, allows us to really go through this spectrum of issues and be better caregivers and providers for the patient.
In like a stepwise format.
Yes.
We had a question, mention one more time, the one or two the geriatric assessment tool that you mentioned. What was it?
There are several, the CARG, C-A-R-G.
Okay.
If you put CARG geriatric assessment in Google or your favorite search engine, it'll come up. And there's a lot of wonderful information for patients, such as what questions should you ask your doctor? Okay. Not everybody knows or has any expertise, so it's a little list there that can be very, very helpful.
Thanks.
Clifford, can I just say a quick?
Of course, Efrat.
The geriatric assessment, I saw that question again come up. So the NCCN also has a geriatric oncology specific guidelines for physicians that really walk physicians step by step in algorithm form and how to apply these assessments, relying on this CARG assessment that Hy mentioned. So for those physicians who are used to using the NCCN guidelines, this is a wonderful tool to really give you a stepwise approach. And then obviously the CARG website can give you those tools with actual access. So there are many opportunities there to learn how to incorporate this.
So glad you brought that up. Excellent practical point of information. Thanks, Efrat. Darcie, back to you, and I'm going to combine a couple questions on you. Again, give us a little bit of insight. It's hard to do it briefly, I know, but a little bit of insight on misattribution or bad assumptions about culture and the difficulty of not having English as your first language. If you could maybe talk about one or both of those together briefly, Darcie, would you?
Yes, and I will be brief.
It's hard, man.
I'll try. Yeah, feel free to cut me off though. So the first thing is, look, culture is everywhere. We all have a culture. We have a culture within our homes. We have cultures at the workplace. We have cultures in this country. We have ethnic-based cultures. We have religious cultures. We all have a culture. And the reason it's important for healthcare organizations and providers or anyone who interacts with patients to have cultural literacy, appreciation for culture, is because that is how patients, that's the lens from which they view their diagnosis, their treatment, their own interaction with that treatment. It's what sometimes will guide behavior. It's what sometimes guides reactions to treatment and conversation. So really, when you think about the importance of understanding and having cultural literacy, I know in the state of California where I'm at, there's been legislation passed around that. It's more than just language, right? It's more than just having someone who speaks the same language. It's someone having the understanding of that person's culture and how that person's culture might intersect with the way they respond to a diagnosis and treatment. Are there home remedies they might be using? Are there religious beliefs that might be impacting whether they are making a decision about treatment or not? When I look at the importance of understanding culture and what gets lost when a healthcare system has not properly or adequately invested in understanding someone's specific culture, is you can't ensure the best health outcomes because you're missing a whole component of how that person interacts and sees their diagnosis and treatment. So really, we look at it. I represent Latino patients, and we look at that as a culture as ethnic based. But when you think about it, we all have cultures that shape how we view the world.
But what are we missing, Darcie? If we don't have that appreciation, what is lost then at that point?
Well, one, it's a missed opportunity to build trust and relationship, right? If you're walking into a place that has no understanding, appreciation, or even acknowledgement of your culture, that's a missed opportunity to build relationship. It's a missed opportunity to build trust. And if you don't have a relationship and trust with your provider, that can cause a lot of interruption and stop in your care. It's also a missed opportunity to be effective and efficient, right, in the delivery of that treatment. It's a missed opportunity to also take what's great about that culture and infuse it into treatment and care. Religion and spirituality are really important pieces of recovery and treatment. If someone has that as a cornerstone of their culture, then it's really important that we bring that in and use it as a way to get the best out of a diagnosis. We heard earlier the talk about social support and family support. In the Latino culture, family and social support are cornerstone, right? So if we know that as healthcare providers about a patient, we know that they're going to have strong family support. They're going to have strong support within their congregations or churches. If you understand that, then you have open to you a wide array of resources that you might be able to use as a care provider in order to help this person achieve their best health outcome. And there was I did have a point about the second question.
The English language, if there's a language barrier, how we get around that?
Yes. So the perspective that I have on language is that it's not a problem that folks don't speak English. The problem is healthcare systems that aren't adequately set up to deal with and to serve patients who speak a different language, right? So I think it's really important to look at it that way. Is the problem and the barrier isn't on the side of the patient. The barrier exists within the healthcare system. And is this healthcare system set up to adequately serve all of its patients, all of its members, all who are insured that are receiving care at that place? Clearly, if you have a language barrier, that's the same issues that we brought up earlier, trust and relationship building. But here's something that's even more important that happens when you have language barriers, and you don't have a healthcare system that is set up to do proper translation. You don't have a healthcare system that's set up to do it all the time. And you're depending on children and family members who are coming don't speak medical grade Spanish or English potentially. There can be actual adverse health outcomes. You could have
the system,
serious health outcomes.
The system needs to adjust. It's the system that needs to adjust.
And I've seen things missed in translation that really have caused adverse health outcomes for patients. It was a translation barrier because the healthcare system wasn't set up to do adequate translation.
Yeah, let's figure out where the problem is. The problem isn't with the patient. The problem is if we're a provider, kind of looking in the mirror. Briefly, again, Danielle, back to you on social support systems. A few of our other panelists mentioned already. Can you sort of encapsulate where we need to go next on the social support issue? I think there's some good models for it out there, but where do you see us going next with it to improve the issue? Danielle.
As pertains to caregivers specifically, there are almost too many answers for the time that we have right now. Again, because caregivers and family needs and family dynamics and caregiver skill sets are certainly not the same across the board. They're different in each situation. But one thing that I will say, since this is a policy summit, I feel emboldened to say this. While it is very wise and true what Dr. Muss said about there not being family caregivers front and center, I know for a fact from many of the caregivers that I support and mentor, and that many of the nonprofits support and mentor, that there are people in many situations, friends, family, loved ones, neighbors, extended family, on the periphery who would love to be in that room and support that patient. But we need to think societally about how we can put the people in those chairs. Do they not have childcare? Do they not have paid time off? What are the reasons that are keeping the loved ones that are on the periphery of this person's lives out of the room? They are there. It is true that we would be nowhere in the work that any of us do without social workers who are superheroes. But we also need to think of the ways that would facilitate putting people who know the patient very well and love them into those chairs. And I think we would all agree that that would foster better outcomes. Now, asking for solutions, I'm not sure. I feel like we're all here because we're seeking the solutions. But as I've said in related conversations before, I think it's better to constantly talk and ask and bring up unmet needs so that solutions can be found as a group. I can't tell you any right now other than to find the ways that make it work. If you have a neighbor who can give you childcare so that you can go to your uncle's doctor appointment with him, you know, you may not have any societal support to figure that out, but there may be a support group on Facebook or facilitated by a nonprofit who can help you think of those solutions. Unfortunately, right now, that's sort of where we are. But the social media space excels in ways that we didn't have before in helping people crowdsource, if you will, solutions to these problems that will put more constituents in the chairs and put more support behind these survivors.
Good.
If you can't think of a solution to an issue, as was brought up before, you know, can anyone think of a way for me to less painfully move my mom? You know, the providers really care about her, but they're not in her home at 3 a.m. when she wants to change positions. There are support systems now for the care partners that did not exist before the advent of social media. Social media, with all its ills, has been a savior for care partners, especially because if you have never faced a specific problem and you go online at 3 a.m, someone has faced that problem and someone can share a solution.
Well, I want to address that. And I'm going to, if you don't mind, I'm going to push the 4 of you. And this is a closing question. And I'm going to ask you to answer it in no more than a sentence and a half. I'll call it that. Okay. And I'll pose the closing question this way. In 2025, let's imagine that we have reconvened this panel. We've reconvened the panel on the very same subject, addressing age-specific needs and preferences through adulthood and various issues we've discussed today. And we say, you know what? We got it right. We're there. We did something. We're really so much better now at addressing those issues. We've overcome these barriers. We did it right. What policy or other system change did we get right to get us to that wonderful point in 2025? What happened that worked? All right, so I'm going to give you about 2.5 seconds to think about that. But yeah, and Darcie, want to start with you and set a good example for all the others with a brief 1.5 sentence answer. There are a lot of things, but what did we get right by 2025? What was it, Darcie? One thing.
I am nothing but if not unruly. We've learned from the pandemic and the way that we have treated people who've been diagnosed with COVID and understanding it is not their fault and they should not have to pay for this treatment. And so 5 years from now, because we've learned this lesson, we expand that to cancer and realizing that it's no one's fault that they've received it and they should have all of their care and support and everything they need to overcome it paid for so that they can focus on just getting better because it's good for public health and it's good for the economy.
Point very well taken. I'm glad we had that recorded. It was 1.5, a long 1.5 sentence, but it was right on point. Thank you. Efrat, sentence and a half. What do we get right by 2025?
I think we've reached out to all providers, support staff, multidisciplinary teams to understand the importance of evaluating patients and understanding their comprehensive assessment and goals before we go ahead and prescribe therapy.
That's actually a very good summary of several points that were made during this hour. Thank you very much. Danielle, what do you think we got right?
Hopefully we've gotten rid of unsubstantial advice given to caregivers as if all caregiving situations are the same. And hopefully we have a way that we can meaningfully pay family caregivers so that they can focus their time on the only life or death situation in their lives, which is usually the care of the cancer patient in their home.
Point on. Thank you very much, Danielle. Well, hi, you and I and our 3 compatriots here are sitting on this panel in 2025, and we're kind of patting ourselves on the back that we did it all right. What do you think we did right, Hi?
I think we've developed a system to provide the time and reimbursement to address all the specific caregiver, cultural, and other issues that we've discussed today.
You got it. Point on. Well, I can't think of a better group of 4 panels to address these issues. And if it is up to me, we will talk by 2025 and see what we've done in the meantime. Darcie Green, Danielle, Pardue, Hyman, Muss, Efrat, Dotan. What a great panel. Thank you for the input. And from the comments I'm seeing to my personal chat, very inspiring across the board. So much appreciated. You are leaders in what you're doing. We'll follow you carefully and lead us. And we'll talk again in, I hope, even less than 5 years. Thank you very much. Take care. Great panel.
Thank you.
Thank you.